It's no secret that you can dramatically improve your diabetes. In fact, even put your diabetes in remission and normalize your blood sugar off medications with a low-carb diet. Add in some time-restricted eating and intermittent fasting, and you could probably do it even better. But is it all because of the weight loss, or is there something specific about the carbohydrate reduction? In a way, low-carb diets can be a victim of their own success because when you compare them against other diets, you tend to lose more weight on the low-carb diet and improve blood sugar more, which leaves the question, is it just because of the added weight loss? I'm Dr. Brett Scher, the medical director of DietDoctor.com, and I want to discuss this with you because there was a new case report published in Frontiers in Nutrition by Dr. Tro. And we're going to have an interview with him about this at the end of this video here. But what his proposal was, or what his conclusion from these case reports was that it's the carbohydrates. That these 3 case reports using low-carb nutrition and time-restricted eating dramatically improved their blood sugar control and did it with very little weight loss. And if you look at the timing of it, the blood sugar improved far before there was significant weight loss. So let's talk about these. Almost 50% of the population having prediabetes or type 2 diabetes. This is an important topic, right? This is really important. And Dr. Tro makes a big point in his publication that the American Diabetes Association, although recognizing low carb as an effective technique for lowering blood sugar, is pretty agnostic about macronutrients. In fact, they say it's not helpful to focus on macronutrients, but instead focus on portion control and reducing your calories. Sort of the standard advice, which may not always work well. So what Dr. Tro is saying is, hold on, we've got some evidence to the contrary. Now, what they did, 3 different patients. One patient reduced his hemoglobin A1C from 12.4 down to 6, and while losing only 10 pounds, which was about 4% of his body weight. And of course, his HDL improved and his triglycerides improved. Another one reduced his hemoglobin A1C from 12 to 6.5. Oh, and by the way, also getting off medication. So that first patient got off insulin and metformin. The second patient got off insulin and liraglutide and only lost 2.7% of his body weight. And the third patient went from an A1C of 11.3 to 7.5, losing 8.7 pounds, which was, again, right about 5%, but he wasn't overweight to start with. And this was done in a self-selected population for people who self-selected to go on a very low-carb ketogenic diet with time-restricted eating. But interestingly, they started by reducing carbohydrates to less than 30 grams per day and waited 6 weeks before introducing the intermittent fasting, which I think is important because of getting control of your hunger, getting, one big change at a time, getting into your lifestyle and compliance before adding another variable of the intermittent fasting, which I think was really good. So what's the conclusion? Does this prove carbohydrate insulin model of obesity is correct? Well, not really. This wasn't a mechanistic study, right? There was some weight loss. It's not that there was no weight loss, but there was much less weight loss than you would expect for this degree of A1C reduction. What it shows is it's a practical study that shows in a practical environment, either for the doctor or for the patient in a real world environment, you can make dramatic changes in blood sugar control with carbohydrate reduction. That's what it shows. And it might not be all related to weight loss because it certainly does seem out of proportion, both from a time standpoint and from a magnitude standpoint, that it's probably not all due to weight loss. Weight loss clearly can reduce blood sugar, can reduce your A1C, can improve your diabetes, but to get off your medications, improve your A1C to this degree, certainly seems like the carbohydrates and the insulin is playing a role. So I think that's an interesting conclusion. We have to be clear, though, this was 3 patients, self-selected. Can't say that we can generalize it to everyone. Be great to see more studies about this with more populations, but this is how it starts, right? When you have a certain belief and a certain assumption that it's due to weight loss and that macronutrients aren't important, you need case reports like this to kind of raise the red flag and say, hang on, maybe there's more to this, so that there can be more studies down the road. So now let's get into our interview with Dr. Tro himself and hear sort of his take on these case reports in this publication. So Dr. Tro, thanks for joining me to talk about your publication in Frontiers in Nutrition. And first, let me say congratulations for getting that published.
Yeah, thank you, Brett. It takes a lot of hard work. I think, we had medical students working on this project, my staff, the health coaches who I mentioned in the paper, and people who really supported us and guided us, Dr. Eric Westman, Dr. David Diamond, Doug Reynolds at the Society of Metabolic Health Practitioners it takes a village to get stuff like this done.
Yeah, and I think it's striking that we don't see many people who are in clinical practice and don't have academic appointments publishing papers. It's uncommon. I mean, it's not completely unheard of, but it is uncommon, and there's a reason for that. So it's hard to do. So you and your team definitely deserve a congratulations for that. Now, I want to get into some of the details about what you found. And look, it's remarkable, as I talked about in the introduction, the average A1C going from 11.9 to 6.7 with an average weight loss of 8.7 pounds. So it seems like that's sort of the main point of these case reports that you wanted to put out, that you can dramatically improve glycemic control without a tremendous amount of weight loss. So tell us about how you interpret that and why you think that's so important.
Yeah, I think the problem is this idea is not really apparent in the medical literature. So if you look at the ADA recommendations as they are today, even though they have given a caveat in the 2019 update that a low carbohydrate diet is an acceptable eating pattern, their guidelines focus on weight loss, decreasing energy intake, portion control, and eating whole grains and fruits and vegetables. Right? This is the mainstay of their recommendation. And one of the most common things that we've seen when long-term trials have been done with low carbohydrate approaches, weight loss has always been credited as the reason for the improvement in blood sugar. Now, with the advent of continuous blood glucose monitors, we've known for the past 4 or 5 years that it is likely not the weight loss that is producing the effects on blood sugar. It's just the carbohydrate restriction alone. But the medical literature hasn't caught up to this new and amazing technology, right? We have prescribed over thousands of CGMs, and so we've seen very often blood sugar improve without much weight loss. But this isn't known and hasn't been published. So I had a medical student, Dr. Kristen Gavidia, she's now a resident, do a rotation with me about a year ago, and she says, well, why isn't this in the literature? And she just took 3 patients at one snapshot of time that she saw just start our program, walk through our whole program, and get to the end of the program. And she said, we should put this in literature. And so we did. And so with her help and the help of some others, we were able to show that you don't need any weight loss at all to improve your blood sugar. And so that's, I think, the important message here is that it's a message of hope, right? Weight loss can be difficult, but what you eat can impact your health right now, even without weight loss. Weight loss takes sometimes a long time, months to manifest. Psychological support, and multimodal strategies. And it can be very, very difficult. And it's often tied to very emotional and, deeply ingrained cultural sensitivities, right? But you can change your blood sugar right now. You can come off insulin right now. You can improve your blood sugar from an A1C of 12 to an A1C of 6.5 off of all medications with just carbohydrate restriction in some cases.
Right. So it's interesting that you said in some cases, right? So it may not be the same for everybody, but these were 3 very dramatic cases. And interesting that if she randomly pulled these 3 people to follow them through, I mean, there are 3 dramatic cases. Now, to be fair, they all did lose some weight. Like one person did lose about 5%, one person lost 2.7%, and another person lost like 4% of their weight. So there was weight loss, but I guess a big part of your point is, 1, the blood sugar improved far earlier than the weight loss happened. And 2, there is sort of this 5% weight loss threshold that most organizations set to say it's above that threshold that you see the glycemic benefits and the metabolic health benefits. And some even saying, above 15% is where you're going to see the most dramatic benefits. But you saw those benefits with much less weight loss. So in your mind, there's the whole debate about calories versus the carbohydrate insulin model. Is this evidence for the carbohydrate insulin model, or would you just even leave that out of it and not even discuss that part?
Well, look, I think what it shows, let's just take what exactly happened and see what conclusions we can make, right? What happened was these patients came off medications, okay? Their blood sugar dramatically improved, and they did not need to lose a quote unquote clinically significant amount of weight to literally come off of insulin and literally come off of multiple medications, right? So what this shows is that the guidelines, which say you need 5% of weight loss to 5% weight loss to produce an effect, is not necessarily true. So we need to adjust these guidelines. We need to at least consider that we don't have enough information, right? Okay. Where we have enough information now to question that guideline, right? And we have enough information to say, wait a second, it's not exactly true, right? And so whether it points to the carbohydrate insulin model for obesity, I'm not sure that you can make those conclusions. Although I am a supporter of that idea, and that insulin and insulin resistance are at the heart of weight gain and weight loss, right? I think really what it shows is the patients can make a change right now, and it can impact their health right now, whether or not they lose weight. The food you eat will dictate how high your blood sugar goes, right? That's I think what it shows.
Yeah, and that's a perfect answer from a clinician standpoint. Like the mechanisms and all that can be studied in a different way. But when you see a patient in front of you, or when someone's at home listening to this and they want to improve their health today, your job is to help that person get better. What the mechanism isn't your job, but your job is getting that person better. And that's exactly what you did in these 3 case studies. Now, but let me ask you, do you think the same result could have happened with other dietary patterns, whether it be a very high carb, very low fat diet, or, a purely plant-based diet? Or could this have occurred with other dietary patterns? Or do you think it's unique to low carb ketogenic diet with time restricted eating?
I think it's unique. I think it's the carbohydrates. Look, we all know that carbohydrates cause glycemia, impact. So, well, you could do it plant-based if it's low in sugar and carbohydrates. You could do it in Mediterranean if it's low in sugar and carbohydrates. So, this is the other problem, is that the ADA says no macronutrient distribution matters, right? You should just adopt a healthy pattern of eating, and that meal timing doesn't matter. Wait a second. It shows that it kind of does matter, right? All you need to do is reduce your carbohydrates to improve the blood sugar and diabetes. Now, I think the weight loss can help improve that underlying insulin resistance, right? I do think that it can help whether you lose weight on low fat or low, Mediterranean or, plant-based. I think that can help. But the most profound reduction is reduction of carbohydrates, right? The most profound impact will come from the reduction of carbohydrates with or without weight loss. And if you look at these 3 patients, again, you can't generalize to everybody. But I think there are some themes that are important. These patients were severe diabetics. And in these severe diabetics, 85% of their blood sugar above normal, let's say 5.5 A1C is normal, 85% of their blood sugar reduction was done through carbohydrate restriction and minimal weight loss, right? And that's not what the current convention thinks. The current convention thinks all of the effect comes from weight loss.
And so where'd that number come from? Where'd that 85% come from? How'd you reach that conclusion?
Yeah, so that conclusion, this is just some basic accounting, right? We were able to reduce A1C by about 5.5 points, right? The starting A1C was around 12. So 5.5 points out of a 7-point, decrease it would have taken to get to out of pre-diabetes, it's roughly 85%. 85% of their excess glycemia was literally improved with just carbohydrate restriction, and literally telling them, don't worry about portions, don't worry about calories, and just worry about carbs.
Yeah. And I think that's the big power, and something you emphasize. You emphasize hunger, and you emphasize sort of the ease of it without having to count and pay attention to those things. And it addresses those, whereas a lot of other dietary patterns may not. So I think that's the other important point. But one other thing is that these were obviously self-selected patients, right? So do you have concern about, self-selection versus randomized? Does it mean it wouldn't apply as well to someone who didn't sort of buy in from day one that they wanted to go this route?
Yeah, I don't think this is general. I don't think you can just take the person off the street with diabetes and say, this is how you're going to eat and get the same results, right? That just won't happen. I don't think you can force people to eat a certain way in a clinical trial. In fact, we've had colleagues who have forced other people with meals in their clinical trials, right? And have completely different results. We had a study very recently by Dr. Nicola Guess, who literally gave people with diabetes meals of differing carbohydrates, right? And so, but you can't force people into eating your food. And if you look at her blood glucose, right, in the CGMs in her study, they were very variable, even at the lowest carbohydrate amount. So this implies that even if you give people food, right, and tell them to do a certain diet, that if they don't want to, they're not going to do it. They're not going to adhere. So I think it's very important that our patients self-selected low carbohydrate diets, right? Because I would have never forced them and encouraged them in this dietary pattern unless they wanted it. And so I think you're absolutely right to point out that, hey, these results are a little bit unique because you're taking somebody who's, very experienced in low carbohydrate approaches, pairing it with somebody who wants to do a low carbohydrate approach, whose baseline metabolic state is most likely to benefit from a low carbohydrate approach. So yes, you're right. We have the ideal setup to prove our point. But I mean, people at home could be in that same position. You could be at home with an A1C of 10 right now thinking, what should I do? The doctor wants to put me on insulin. Which diet should I do? And you may have, a prominent researcher saying, as long as you lose weight, it doesn't matter. Well, that's not necessarily true. Okay. And you may have another prominent researcher say eggs and meat cause diabetes. And we know that that's not necessarily true. Right. So the problem is, and these are the balanced diet and vegan proponent, messages. Like, I know they're not exactly, there may be strawmans of their message, but this is how people interpret them. Right. Yeah. So I think that it is meaningful that patients self-select, and it does make our study highlight the best potential.
And that's a great point, because that is the real world example that most doctors are going to encounter and most people themselves are going to encounter. We're not provided our meals. We don't live in a metabolic ward. This is the real world example for clinicians. So I hope clinicians pay attention to that rather than criticize it for not being randomized, but to see the potential of it, exactly like you said. So now you've had case reports of disordered eating behaviors, of triglycerides, and now of profound blood sugar improvement. So already a series of 3 different case reports. What's next?
Oh, you're going to love this one, Brett. We have a study with some heavy hitters. I don't want to give away too much, coming out on LDL. And it is going to be fantastic. It is going to be fantastic. So we have great people behind that one, really prominent researchers who have much more experience than I do, helping me get that one out and really taking the lead, I should say. And so that's very exciting. That's the most exciting thing for me right now. So yeah, we're going to continue. And I think after that, we'll probably take a pause, after this last one. I've made my point, like, you can't bias against low carb because it improves binge eating. You can't bias against low carb because it improves hypertriglyceridemia. You can't bias against low carb saying that it's weight loss. It's not. And then what to do about LDL, that LDL that always comes up in that increased in some cases in low carbohydrate approaches, not all the time. Some systemic analysis have shown there's not much of an effect at all. Others have shown a mild increase. Well, we're going to show how to deal with that.
I can't wait for that. That's awesome. I
will right up your alley as a lipidologist and a cardiologist. So you're going to love it, I know.
All right, let's get you on the schedule for another interview for when that comes out. So thanks for all you're doing. Thanks for promoting this. And I look forward to more discussion about it.